and welcome to ACR Journals on Air podcast. I am your host, Vicky Shanmugam. Everyone remembers the first time they encountered the complement cascade in medical school. It's confusing, and indeed, I remember that the introduction to my immunology textbook had a quote stating, "Immunology is the invention of the devil, who is making it up as he goes along because he's not too clear about this stuff either." So I was excited to hear that the journal Arthritis and Rheumatology has launched a new immunology series to refresh and update, to complement, if you will, our clinical rheumatology knowledge. The manuscript we will discuss today has the dramatic and catchy title, Complement. A link to the manuscript and disclosures are in our show notes from today, and I'm delighted to be joined by the manuscript author, Dr. Paul Monarch. Dr. Monarch is Chief of Rheumatology at the Veterans Affairs Boston Healthcare System. He has focused his career on clinical and translational research in vasculitis, including biomarkers, genetics, and clinical trials. He is a long-standing member of the Vasculitis Clinical Research Consortium and contributed to the Immunological Genome Project Consortium. He has led studies focused on identifying new markers for diagnosis, staging, and assessment of disease activity in vasculitis, as well as predicting the course of disease. Welcome to the show, Paul.
Well, thank you for having me. I really appreciate the opportunity.
So, Paul, I wanted to start with some background about this manuscript. This was something you were invited to write by the editors of Arthritis and Rheumatology, and the format is a little bit different from a typical review article. There are several points throughout the manuscript where you use a writing tool called bottom line upfront messaging. This is a technique that I think was coined by the military for communication. It's also recommended in the book Writing for Busy Readers, which I'm currently reading. Can you tell us about why you use this communication technique?
Yes. So I work at the Veterans Affairs Hospital, and that's exactly where I learned it from somebody with something like 30% of VA employees are veterans. That's where I learned it. It essentially does the same kind of thing that I would try to do when writing a memo or writing a complicated email and saying, I'm writing to ask, boom, one sentence. But it's a very helpful way. I'm very long-winded. I write very long emails. And so doing it up front to just say bottom line up front, I think works really well. The other thing I just want to mention in passing, another nice military tradition that people use, but I haven't adopted myself because I'm not sure I'm allowed to as being not a veteran, is to have their sign off be very respectfully or V/R. So if you see that, it's probably a veteran. And even if you don't write that, it helps remind you to be nice in an email because it's a lot easier to be mean in an email than in person. And I think it's a very nice thing that they do.
Good life advice. So the complement system is complex, and the more we learn about it, particularly diseases and drugs that impact the pathways, the more complex it seems. You wanted to bring a clinical relevance to this review article, and so you framed the introduction to the article with a clinical case. Can you talk to us about that case?
Yes. So I deliberately made it obscure with I was hoping this would be entertaining in sort of a rueful way for rheumatologists by including a whole lot of lab tests that are sort of borderline abnormal that other people would get worked up about and that we have to contend with all the time, like trace cryoglobulins, trace blood and protein. The patient is dehydrated, is the creatinine really elevated or not? I think a borderline rheumatoid factor. I didn't go too overboard, but it's really the opposite of a board's case. But it's real life, and we see a lot of patients like this all the time. And in the middle, I included clearly abnormal complement proteins C3 and C4, which are not definitive for anything, making a diagnosis, as the entire rest of the chapter is about, and as any clinician in rheumatology knows, but it helps maybe put those other things in a different context.
So you kind of walk us into this overview of the complement system, including those crazy diagrams we all learned in medical school. But you've added a little bit of a twist, which is that you bring in the clinical diseases we now understand to have complement-driven mechanisms, and you overlay currently available FDA-approved drugs. I'm wondering if you can put those figures into words for our listeners.
That was the main thing I was happy about being able to do and having it sort of work out with the help of a professional artist to redraw what I drew in PowerPoint. To me, it's much easier to understand what the complement cascade does in a medically relevant. First of all, it makes it medically relevant, but it's easier to understand what the different components do when you can associate them with infection risks or risks of autoimmune diseases. And now with drugs being available, what the benefits, where diseases where those are going to work, diseases where they're less likely to work and aren't being studied, and also the infectious risks. And fortunately, that's all sort of falling together. So I led with deficiency syndromes, not because we see them that often, except maybe some pediatric rheumatologists who are also immunologists. Not because we see them that often, but because it leads then into what the treatment's going to be. So the deficiency syndromes on the alternative pathway side, actually, and on the classical pathway side as well, for infection risk, it's pretty broad. It's a lot of encapsulated bacteria, and also I think Neisseria are encapsulated as well. But what I think we all learned in medical school was at the bottom, if you're deficient in making the membrane attack complex, the MAC, then you're specifically susceptible to Neisserial species. And that's true. But if you're missing the things that are higher up, you have a much broader range of susceptibilities. And that ends up being borne out with the drugs as well. So that's one of my panels, is just linking some of those things together with the infection risk, so that it's the alternative and classical pathway deficiencies that have a broader bacterial risk. With autoimmune diseases, that gets more in what we do. But there on the classical side, even though it's considered rare, it's pretty well known that deficiencies on the classical pathway side, C1, C2, C4, are associated rarely with cases of lupus. On the other side, maybe we don't hear about it as much, but it's associated with atypical hemolytic uremic system, uremic syndrome, or AHUS, which is something that nephrologists see, although still pretty rare. And then when you get to, I have a panel that then overlays the drugs, and it's a similar kind of thing. So the drugs that have been developed to block the complement pathway on the classical side are targeted at diseases that are known to be dominated by classical pathway activation, although that's still very much in its early phases. And as far as it's thought anyway, that the risk of encapsulated bacterial infection is higher as well. There's only been a little bit on the side of the alternative pathway as well, but a little bit. And some of it is a little more exciting as we'll get into, because it's more local diseases rather than systemic diseases. And then as we'll get into, agents that block C5 activation entirely are ones that are used to block diseases that are utterly dependent on all aspects of complement activation, including development of the MAC complex, whereas it is possible to block specifically the side that goes to create C5a, which is an old-fashioned term anaphylatoxin, but a chemotactic agent, especially for neutrophils, as we'll get into.
So kind of leaning from that back into the clinical arena, we kind of get to your bottom line upfront message. You say low levels of circulating C3 and C4 are always abnormal. Tell us more.
I might have overstated that a little bit. It's a self-fulfilling prophecy. What I was thinking about at the time was in comparison to some of the things I used in the case that we all know. Low titer ANA, low titer rheumatoid factor, low titer anticardiolipin antibodies, trace problems in the urinalysis. And then, the one chemical laboratory protein test that we look at, CK, is, known to be highly problematic. So in a sense, the measurement of C3 and C4 follows the same rules of laboratory medicine of the 95% confidence interval of healthy people. But we're more interested on the low side than the high side. And on the low side, a low-level deficiency of C4 is pretty common. So in a way, that's, quote, normal, but it's a common enough polymorphism that it has a genetic cause. It isn't just sort of a random thing. And so that's really more what I meant, that it always indicates some objective abnormality rather than just being a statistical quirk. But that doesn't mean it's pathogenic. And so we will occasionally find patients who have a very slightly low C4, and it might have nothing to do with their health.
So I need more information because this sounds more nuanced. So C4 underproduction can be related to different phenotypes. Is that correct?
Yes. So C4 is a complicated gene. For starters, it isn't one gene. So there's a C4a and a C4b, and the quote normal state is to have 2 copies of each, but it can be duplicated, and you can have, because it is redundant, you can have insufficiency as well. So it's fairly common to be missing at least one of the 4 copies you would normally have. If you're missing 2 copies, certainly if you're missing both versions of C4a or both versions of C4b, there's an increased risk of lupus. But it's been reported, I think, as 1% to 2%. But, these are hard studies to do to really know for sure what the risk is. I'm not sure that missing just 1 copy of any of the C4 alleles is sufficient to give infection risk. It might, but it's on the mild side. So you can certainly run into people who are missing one copy of, and you never go look for it, but who have a very, very slightly low C4, who are healthy. And at most, they might have had a few more infections than others do, but not necessarily serious ones and not highly predisposed to autoimmune disease.
Yeah, important to know. What about acquired causes of low production? So classically liver disease, right?
Yes. Again, unfortunately, I wanted to look into this myself and go back and look at the literature rather than relying on what I thought I knew. And it just hasn't been studied that much, unfortunately. You would expect that you would see a reduction in C3 before C4 simply because it's such an abundant protein. It's one of the most abundant proteins in the blood. And so sort of like getting low albumin, it might be something that the liver just can't make enough of, but it can make some. But I think it just hasn't been studied that much. It's sort of like CRP. People don't really know how much liver dysfunction can reduce the maximum amount of CRP, the amount of CRP that you can make in an inflammatory state. So it's mentioned in all reviews, but hasn't been studied very much.
And actually, that gives me a nice kind of transition. I'm wondering if you can give us a bit of an update on labs now. We're obviously all pretty experienced at ordering C3 and C4, but when would you recommend ordering the C1 inhibitor levels, other complement proteins? And when I trained as a fellow, I always remember including a CH50, and that kind of fell out of favor, I think, because the lab testing was not very good. Is it ever useful anymore?
I think so. And honestly, I wouldn't be surprised if it's gotten worse, that it's become a lost art. I think, labs that did it a lot were quite good at it, but labs that didn't probably were never quite as good. It takes longer to come back. And I think the C3 and C4 assays are considered reliable enough that you don't really need to look at the functional assay. Where the functional assay, I think, ends up being very important, and this I have no experience doing it, is when people are looking for genetic deficiencies. And the difference there is you might get a relatively mild abnormality of some of the other proteins, but see a dramatically reduced CH50. And there's even, I've never ordered it, an AH50 to look at the alternative pathway side. And I think, again, you're really detecting genetic deficiencies if you do that. With the C1 inhibitor, I really think that's only, as far as I know, only appropriately sent in the setting of a patient with angioedema. Whether that's hereditary angioedema or otherwise. I personally have only seen one case in a patient with lupus where it's immune mediated. I'll just say in passing, I know nothing about the different tests to look for to C1 inhibitor or C1 inhibitor blockade, and which is appropriate in the right setting.
And so now, can we get back to C3 and C4? Because I do think those are the most commonly ordered tests by rheumatologists. Can you help us understand situations where there can be discordance between C3 and C4, where there's complement depletion, but one of the components is out of proportion to the others? I think you have a table in the manuscript where you walk through a couple of different scenarios. Can you explain it to our listeners?
Yes. And unfortunately, typical of rheumatology, it's not as clean as we would like once I really looked into it. So a lot of that table, rather than just saying low or normal, will say low/normal or normal/low. I think for us, two of the conditions where the differences are pretty common is that in lupus, it's usually both C3 and C4 that are low. And in cryoglobulinemia, which maybe I have seen in my career more than others have, it's often the C4 depleted way out of proportion to the C3. And then beyond that, it's more, most other diseases that we see don't really deplete complement that reliably, even if autoantibody formation is part of it. So patients who have vasculitis in the setting of Sjogren's, or we don't see a lot of rheumatoid vasculitis anymore, that one, yes, you can get complement depletion, but you don't have it as reliably. And then just in passing, I'll mention that the condition hypocomplementemic urticarial vasculitis by definition is complement depleting. So they're going to be low, and it's typically both of them. But there's always a problem when a disease is defined by a lab test. It's, in a sense, impossible for those to not be low in that disease. If I could just go back, I left out of the table because it's not something we see in rheumatology. This set of rare renal diseases called C3 glomerulopathies, I think that the one that we might run into rarely is a C3 nephritic factor. There's an antibody to C3. I think there's even a C4 nephritic factor, and that can activate the alternative pathway alone so that you get depletion of C3. And then on biopsy, renal biopsy will see C3 deposition in the kidney and not antibodies or the classical pathway of complement. So that's another one that rarely could head you in the other direction.
And every so often we get consulted as a clinician for a patient whose complement levels are above the normal range. And when I was a fellow, this was a consult that always made me whoop with joy because it was not my disease. Do you agree?
I do. I don't know of, and I haven't found any reason to have elevated C3 and C4 that are pathologic other than as acute phase reactants reflecting inflammation nonspecifically. If there's anything else, I'm not aware of it.
So very occasionally also as a clinician, we consult on patients who have very clear clinical manifestations of small vessel vasculitis, but there does not appear to be a complement consumption, or certainly the measurable complement levels are within the normal range. How does that happen?
The analogy I made, which the editors grudgingly allowed me to keep, was of an undersea volcano. I initially said iceberg, and then I realized that was backwards. That the process going on at the cellular level, the molecular level, is the same, and it's only if it just reaches a certain magnitude that you'll see systemic depletion. So the amount of complement is being deposited in small vessel vasculitis. It's actually the antibodies are being deposited in small vessel vasculitis in a lot of places where there's no purpura, no evidence of vasculitis. So it first crosses that threshold to become clinically apparent. And I think you just have to deplete fast enough that the liver can't keep up. That's the way I interpret it anyway.
Scenarios of almost kind of grumbling vasculitis then. So there are also some complement-driven diseases like neuromyelitis optica, age-related macular degeneration, myasthenia gravis that don't have a measurable way to implicate complement, or at least not right now. But we're pretty sure complement pathways contribute to disease. Can you tell us how we know?
Yes, it's a combination of molecular techniques that became available, I think, past 30 or 40 years. And one thing I was taught in my training to not go into in immunology was complement. And at that time, it was all about classical biochemistry working with unstable proteins. And things changed dramatically with the development of immune fluorescence, immunohistochemistry, genetics, human genetics, and the genetic manipulation of mice. And it was a combination of all of those things that were adding up. I know the story of macular degeneration the best, that led to identification of complement being deposited, implication of factor H, relative factor H deficiencies in some cases. And then once the evidence is strong enough, then you develop drugs and you try them in animal models if you've got them. And then if those work, you go to humans. And it's an amazing success story. And I think the AMD story was obviously surprising to most of us. But to me, the neuromyelitis optica and myasthenia gravis were kind of surprising as well, because unlike the hemolytic diseases, not necessarily implicating complement as essential for either modulating a receptor or facilitating phagocytosis. So at least I was kind of surprised. And it's nice to see complement opened up, the possibility of complement inhibition opening up to a much wider range of diseases.
I'd love to hear more actually about the background for AMD. Do you have more information?
That's really all I remember, is that it is stained retinas showing deposition of complement products. There was at least haploinsufficiency of factor H, which is an inhibitor, being associated with genetic AMD. Well, I don't know what proceeded in terms of modeling in animals and how the process of proceeding to drug development went. I just know that the human genetics and the tissue staining together, really the kind of things that you couldn't do before 1990 or so.
So that gives me a kind of nice segue into complement inhibitors and new drugs. There are now, and caveat by now, I mean at the time of this recording, 7 FDA-approved drugs that inhibit various pathways of complement activation, and they can be grouped by mechanism. And I'm wondering if you can talk us through them. I'm going to start at the bottom of your table because it's the most immediately relevant to rheumatology. Avacopan, the oral inhibitor of the receptor C5a. How does it work and when should people use it?
It's exactly what you said, an oral inhibitor of the receptor for C5a, which is an important chemotactic receptor for neutrophils. It was found, again, by a series of molecular studies in a mouse model of ANCA-associated vasculitis to block the pathogenicity of anti-MPO antibodies. So For a lot of us, this was again surprising. You could see that ANCA-associated vasculitis isn't non-immune in terms of deposits in the kidney, but it's posse-immune, just that there isn't a whole lot there. And people had to look pretty hard to see evidence of immune complexes. But it was found that not only was the development of glomerulonephritis by anti-MPO antibodies dependent on neutrophils, but it was also dependent on C5. And with this inhibitor used in the mouse model was found to be dependent specifically on the C5a receptor on neutrophils, presumably through chemotaxis. And so that led to its development specifically in ANCA-associated vasculitis, which is the first time I know of a drug being developed to treat vasculitis rather than being repurposed from something else. So the situation in which I would use it is really just based not on theory, but on the single large clinical trial that's been published and that which I participated in but didn't end up enrolling patients in. And I think the case for using it to replace prednisone in patients with renal disease is very strong, and mostly based on not because it's better, but because it's non-inferior to prednisone, and we know how toxic prednisone is. There's a lot that isn't known about the drug, about what its infection risk is, whether it works for remission maintenance on its own versus compared to rituximab. So it needs a lot more study, but I think just knowing how risky prednisone is, that it's a really solid thing to consider for patients with renal disease in particular, because they might actually have better outcomes rather than just similar ones.
And there are now also 2 C5 monoclonal antibodies, eculizumab and ravulizumab. What are their indications and how do they impact the complement cascade?
They're going to block the cleavage of C5, so C5a doesn't get made, and you also don't get the MAC complex. So it's likely that they would also work in ANCA-associated vasculitis, but they do carry an infection risk. Not surprisingly, similar to deficiency syndromes of neisseria infections. What they're used for is diseases where complement activation leading to lysis of cells by MAC is important. And so the first one was PNH, paroxysmal nocturnal hemoglobinuria, which is an actually acquired deficiency, acquired in adulthood, missing some inhibitors on the red cell surface. And then actually, I believe it's atypical hemolytic uremic syndrome. I believe both of them are also approved for myasthenia gravis. One of them is approved for neuromyelitis optica. I'm not sure which one. I mean, I think it's reasonable to expect the other one does as well. I mean, that's the problem with drugs like this, is that their development is dependent on the best guess of what disease to look at, who is committed to doing it, and the circumstances of the company of, is it financially worth it? And when it's rare diseases, those are not trivial considerations. When I looked this up just in clinicaltrials.gov, they're being looked at in thrombotic microangiopathies, in acute transplant rejection. People use it for Degas' syndrome because complement seems to be involved with variable success, but that's otherwise a fatal, untreatable disease. Like I said, as expected, neisseria infection risk is, I think, known to be higher. Maybe it's just presumed to be higher. Whether other things are at higher risk hasn't been reported as far as I know, but we don't necessarily know what to look for. So you find the things you look for, and then maybe it takes more time for other things to come out. But it's been a big advance, I think, for those diseases. That's my understanding. The interesting thing to me is, like I indicated before, that benefit in diseases where I really wouldn't have thought that lysis of cells by the membrane attack complex is helpful, just like myasthenia gravis and NMO, opens up the possibility that a broader range of truly autoantibody-mediated diseases might be benefited by complement inhibitors in different ways. I think if autoantibodies are just part of a much more complex set of abnormalities, like in rheumatoid arthritis, maybe wouldn't be as optimistic. But for the diseases where you can really nail down the autoantibody and say, if we could get rid of that or keep it from doing what it's doing, the disease is going to be much better, that the broad complement inhibitors are worth looking into.
Yeah, it'll be interesting to see what the future holds, right? Tell us now about the C3 peptide base inhibitor, pegcetacoplan.
So I hadn't heard of this before I did the article, because again, it's more on the renal side. So it's approved for atypical hemolytic uremic syndrome, which is characterized by large-scale activation of the alternative pathway and not the classical pathway. And it's in trials for C3 glomerulopathies, which is a diverse group of rare diseases, like I said, and membranoproliferative glomerulonephritis. But maybe it's not going to go quite as far systemically as the C5 inhibitors do. It could, but blocking C3 based on other studies, I think, of acquired deficiencies or genetic deficiencies is thought to have maybe the highest infection risk of all. I don't see it necessarily replacing more targeted parts of the pathway. But what's fascinating about this one is that an injectable form of it is approved for a subset of macular degeneration.
Oh, interesting. I didn't know that. So we also have a few different agents that work on C1. There are obviously two proteins that are available replacing the C1 inhibitor, which are primarily used for hereditary angioedema. But there's also a monoclonal antibody of C1s called sutimlimab. It's FDA approved for cold agglutinin disease. Tell us about that agent. How does it work, and is it being studied in any other diseases?
Yeah, so not a whole lot is known about this drug, at least in the published literature. Cold agglutinin disease, quite rare. I only found one published paper with the trial that led to its approval had 60-some patients in it. So yes, it blocks C1s, and so the entire classical pathway doesn't proceed from there. And that is a disease in which agglutination of IgM, I think in the absence of a specific target antigen, binds enough to red cells to get them lysed. So the hemolytic part of cold agglutinin disease gets treated by that. Consequences of the disease that are caused just by aggregation of IgM do not. So far, not much is known about the infection risk or whether there's a risk of developing lupus, because if you have a C1 deficiency, genetically, you have a high risk of lupus. So no one knows yet. But the diseases in which it's reported to being studied is at least some form of ITP. I think personally, even though it's really hard to do trials in these diseases, that cryoglobulinemia would be a particularly good target. Like I said, this is from large complexes of antibody and usually antigen as well for what we call the type 2 and type 3 cryos that are associated with rheumatic diseases rather than hematologic malignancies so much. It's something I hope someone could study, even if it's just in the form of, a non-randomized trial in that disease, because cryoglobulinemia is often quite resistant to treatment.
So kind of the yin and the yang, I guess. We'll see what plays out for the immune system as these agents get further developed. I want to cycle you back now to the case you presented at the beginning of your review, because at the end of the manuscript, I don't want to give the game away, but you kind of wrap it up in a way that very much reminded me of one of my mentors, Dr. Thomas Cupps, who was famous for saying, you don't have to name it. You just need to know how to treat it. Was that what you were thinking as you put this case together?
Yes, exactly. Except the senior clinician I wanted to pay tribute to was Ron Anderson, who's an ACR master, was my program director and program director at the Brigham for, I think, more than 30 years. He had a lot of good sayings, which I've quoted to other people over the years. But one of them, I'm paraphrasing, was sometimes the most important thing you need to do is to tell the patient, I have no idea what's wrong with you, but I'm the person to see for it. So, similar way of putting it.
Yes, I'm sure useful even now, probably in your career, right?
Very much so. When you see patients with vasculitis, you see a lot of patients who they got something, but it may not be a name form of vasculitis, but it's something and you need to do something about it.
Which brings me nicely to your career. You completed your undergraduate degree at Harvard. You then moved to Chicago to complete your PhD in immunology and followed that with an MD. What made you pursue the medical degree after your PhD? And were there other mentors who helped you along the way? And what advice would you give to fellow scientists who are pursuing medical degrees after PhDs?
Sorry, I should have made this clear. When you look at you see the degrees 5 years apart, but it actually was part of a combined program from the beginning. But I jumped to the lab after only 1 year of medical school, and then I lingered in the lab for a couple of years after I got my degree and then went back. So
good to linger.
Yes, I was glad I did that. I no longer do basic science work. I actually stopped doing that in 2007. I was lucky to have a lot of mentors along the way. I mean, in the lab, various people who were excited about lab work kept me involved in it for a while. The one thing my lab mentors in my last postdoc, it wasn't that I had a bad experience. I had a very good experience, but just looking ahead of me, this was with Christophe Benoit and Diane Mathis, that I looked ahead of me and saw that what the most successful people doing lab work were doing was not something I wanted to spend time on. And I had just found that, and I'm lucky I've gotten away with it, that I liked seeing patients. They were great in they're not MDs, not clinicians, and they were great in letting me do 2 clinics a week. Some people in labs, especially that aren't in medical departments, get pushback on doing any clinical work. I found that I liked doing clinical medicine, but I didn't like doing it a lot. And so I've managed to have somewhere between 1 and 4 clinic sessions a week and do research in some other way. Honestly, I don't know if I could have taken the leap easily to try to fund 90% of my effort to do basic science research through NIH grants. That's just my own personality. I also found that I liked doing work and liked thinking about scientific projects that I knew were pretty close to clinical medicine. And so that's how I ended up in clinical research. My next important mentor there was Peter Merkel, who was at BU at the time, who taught me vasculitis and was one of a group of important people in teaching me how to do clinical research. And I've managed to do that ever since. And how do I sort of advise other people? I think they just need to decide what they like and what they like best. There are ways to be primarily a clinician and do research, but not by running a separately funded lab. If you really want to combine things, the easiest way to do it and to be good at it is to have a pretty narrow clinical specialty that you do. So obviously you can't do that in a private practice, but a lot of universities, like for me, vasculitis, I tell people all the time, I'm not the guy to see for back pain, but I don't see a ton of patients, but I've seen way more patients with vasculitis than most even sort of lifelong clinicians have.
And you've had obviously this very illustrious career successfully combining clinical trial work with translational work in immunology. You also now serve as chief of rheumatology at the VA in Boston, which is a lot to juggle. How do you keep all the balls up in the air?
I actually tell people this all the time. I made up this little analogy that if you're going to do too much, if you can juggle 4 balls and someone throws you a 5th one, you have 2 choices. You ignore it, or you try to catch it and you drop them all. So I've tried to avoid dropping them all in different ways, but I've kind of diversified the things that I do. So the administrative jobs that I've had, the first was being a fellowship program director at BU, and then being chief of rheumatology where I am now. That's nothing like being a program director in cardiology. We'd have 2 fellows a year at a place where we would get great people. I have my department that I supposedly run. We have 2.5 clinical FTEs, full-time equivalents. So it's not big. These are small. Everybody you're dealing with. It protects a little bit of time. And then the other thing is the research that I've done and what I really enjoy doing. Now I do a lot of almost administrative, like scientifically, medically informed administrative work running clinical trials at the VA. And it's all big science. One way or another, it's collaborative. Your whole job is to work together, not to be competing with each other. And that really enabled me to have research funding for a long time with the consortium that Peter Merkel has led called the Vasculitis Clinical Research Consortium, which was funded for 15 years. And so that way I wasn't completely dependent on having one or certainly more than one individual investigator-initiated award all the time. I wish there were more opportunities for young people going into academic medicine to stay involved in research, but not have to make that commitment to 80 or 90% effort.
I think that's really good advice. And now that you're more senior, what are you doing to mentor others in our field?
That's part of it. People come to ask me for advices all the time, and I'm not sure they always get the right advices. I always say, well, this is what I did. And to think about it's sort of a platitude, but what do you love doing? If you don't love doing any of these things, what do you like best or dislike least? And I think the decision that a lot of people are asking, they know what they want to do, and they're thinking more like, what's the best type of institution, whether it's specific institutions that I know about where I know people. And so that's relatively easy. One of the hardest ones, I think, is for people who are in the basic sciences in particular to consider whether they go to industry or remain in academia just because of the workload it takes to get grant proposals. And I didn't go that route, so I don't really know to that extent. I know a lot of successful lab-based researchers, even within my own age. It's not like it doesn't happen. But I think the clinical research pathway I'm better informed to tell people about, because I do think it's easier to combine a very part-time clinical career where you have a particular expertise with research that is either your own or in combination with others. I think there are more opportunities to do that in academia.
So complementary in a way.
Yes.
I love that discussion, Paul. Thank you so much for joining us and sharing all your wonderful insights.
Well, thank you very much. I really appreciate it.
So today, my thanks must also go to our immunology teachers. The topic is difficult and ever evolving. Medical students facing material for the first time may sometimes feel overwhelmed, but clinical care places the immune system in context where it can become a source of wonder and lifelong learning. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.